So we now take the OAU anthem. Okay, Great Ife. 1, 2, 3, go. Great Ife, Great Ife, Africa's most beautiful campus of the and progressive. Luther is taste all oppression. Forward, never backward, never for cleaning our culture. Great FM, I love you. There's only one great FM in the universe. Another great FM is a counterfeit. Great, 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 great. All right, thank you very much. We can have our seats. Welcome once again to this beautiful occasion, the 14th Professor Adetokunbo Lucas lecture. I'm glad that we're all seated from far and from near. To kickstart, I would like to welcome our guests, particularly our guests, special guests to the high table. And as I call them, please, I want you to give them a warm and a beautiful round of applause. All right, so first, to kickstart, I'd like to welcome the Vice Chancellor of the Obafemi Awolowo University, Professor Simeon Bamire, who is ably represented and is also here in his own capacity as the Deputy Vice Chancellor of Research, Innovation and Development in the person of Professor Akiemi Akon. Please, can you make him welcome? Thank you very much. You're very welcome. Also, here with us, and to like to honor and to also have on the high table with us is a former DVC who we specially invited for today's occasion, and retired but not tired. And that is in the person of Professor Mrs. Biket Stedt. I believe I got that right. Please, Emeritus, please. I apologize if I didn't get that name very correctly. You're very welcome. Thank you very much. Please, let's just give her another round of applause. Thank you very much, ma'am. Also with us today is the provost of the College of Health Sciences in the person of Professor Bernice Adegbengbe. Please let us make our welcome. Please keep clapping until she has her seat. Thank you very much. Also with us is the provost of the Postgraduate College, but ably represented here today by Professor Okonji. Please, I'd like to Deputy Provost of the representing the Provost. Thank you very much, sir. Please, this will make you welcome. Please give him a round of applause as he comes. Thank you very much. Today, we are especially honored to have two guest speakers who are eminent in their field, particularly on the research of today. We'll hear a bit more about them, and then we will also listen to them as they give us from their wealth of knowledge. But at this point, I would like to welcome them to the high table. And I'd like to start with Professor Olumide Ogundaunsi. Please make him welcome. Thank you very much. Please keep clapping, keep clapping. No, not by design, but we found that both our guest lecturers are products of OAU, one way or the other. Please, I want us to celebrate that. We didn't think about that, but that was how it turned out. And we're really grateful. Our second guest speaker, all the way from FCT Abuja, she arrived yesterday, and she's with us. I'd like us to welcome Dr. Olushola Oresanya. Please keep clapping. Dr. Oresanya, since you're amongst many professors, I wanted to give you Professor, I didn't say Professor Oresanya, but we'll talk about that later. You're very welcome. Also, I'd like to recognize also the wife of our guest speaker, Professor Mrs. Ogundaunsi. You're welcome. Thank you very much for accompanying. Thank you very much. Also today, we'd like to invite to the high table a former director of the Institute of Public Health, a former provost of the College of Health Sciences, a former VC of the University of Medical Sciences, Ondo, and is with us today, honoring us. I know that the Lucas lecture started at the time when he was the director, and we are glad that we are keeping the flag flying. Please, let's welcome Professor Adesegun Fatosi. And last but not the least, I'd like to welcome my director, who has been the engine behind all that we are doing. I want to celebrate with me and welcome Professor Olakpeju Esimai. Please celebrate her and make her welcome. Of course, there are eminent persons in the auditorium that I would like to recognize from different departments, different faculties within the college, and also persons from outside the university. Of course, as the program goes along and as names are passed to me, I would recognize them. Please, the IP secretary, can you step forward for some information? All right. So first, I'd like to recognize Professor Mrs. Fatosi, who is here with us. And I should mention that Professor Mrs. Fatosi is the chairman of the Health Research and Ethics Committee that is situated within the Institute of Public Health. So she's part and parcel of what we do in the Institute of Public Health. So you're very much welcome. All right. So with us also is the Dean of the Faculty of Basic Medical Sciences, the President Professor Adeyemi. You're very much welcome, sir. Thank you very much. All right, please, let's give him another round of applause. Thank you very much. Also with us is the Dean of Basic Clinical Sciences, and that is in the presence of Professor Aboderi. Thank you very much. You're very welcome. He's also part of us, part and parcel of what, in fact, Professor Adeyemi is also part of what we do in IPH. Thank you. So as I also see within the congregation, or rather, apologies, within the crowd, from the Department of Community Health, Professor Oluokere, you're very much welcome. Professor Dr. Adeyanju, also from Community Health, you're very much welcome. Professor Faponle from Anesthesia, you're very much welcome. We thank you for coming today. As we go along, we will give us more information. All right. To take this program forward, I'd like to invite the director of the Institute of Public Health, Professor Peju Esemai, for welcome speech. Please let's give her a round of applause.
Good morning, everyone. My welcome address. It's my profound honor and privilege to welcome you all to the 14th annual Professor Adetokunbo Lucas lecture. And before I continue with my lecture, I want to actually recognize the dignitaries on the high table. So the Vice Chancellor in absentia, Professor Simeon Bamire, the Deputy Vice Chancellor of Research, Professor Akoni Akinyemi, the former Deputy Vice Chancellor Academic, who is like a mother to me, Professor Mrs. Bickerstead, the Provost of the College of Health Sciences, Professor Adigbenbe, the Provost of the PG College, who is represented by Professor Konji, who came very early. Thank you. And then the Deans of Basic Medical Sciences, the Dean of Basic Clinical Sciences, our esteemed guest lecturers, and then also other dignitaries present in the audience. I will also note, but also appreciate our Professor Mrs. Fatusi, who has been holding forth for our research, HREC. Thank you for coming, ma. And then our students who are here today. So I continue. Each year, the Institute of Public Health celebrates an enduring legacy, that of an icon, a scholar, or rare distinction, and a global trailblazer in public health, Professor Adetokunbo Babatunde Lucas, whose birthday we fondly commemorate today, November 25th. And that's why we do it November 25th every year. Professor Lucas devoted his life to advancing knowledge, shaping policies, and strengthening health systems across the world. His commitment to science-driven solutions and human development continue to inspire generations of researchers, policymakers, clinicians, and development partners. Today's lecture is not just a ceremony. It is a reformation of the values and vision he stood for. This year's theme, Turning Evidence into Action, the role of implementation research in policy and practice, could not be more timely in a world where scientific findings abound, yet gaps persist between knowledge and the real-world outcomes. Implementation research offers a bridge we need, ensuring that innovations are not just discovered, but delivered, not just debated, but deployed, not just theoretical, but transformative. As we reflect on Professor Lucas' lifelong advocacy for operationalizing evidence in global health program and tropical disease control, we are reminded that data alone does not save lives, action does. The challenge before us today is how to strengthen the pathways that translate rigorous research into effective policies and sustainable practices that improve health for all. Today's lecture provides us with an opportunity to deepen dialogue, share experiences, and inspire collective commitment to this vital mission. I thank you all for joining us on our legacy that continues to emulate the future of public health. I wish us all a meaningful and impactful lecture session. You're mostly welcome, sirs and mas. Thank you very much.
Thank you very much, Professor Esemai, for that welcome address. Welcome speech. All right, so following our program. I'm going to now invite the call for remarks. First, from the Provost of the College of Health Sciences, please make welcome Professor Bernice Adegbengbe. Let's give her a round of applause.
Thank you very much. So good morning, everyone. Yeah, while I want to observe the existing protocol, I would like to appreciate our Vice Chancellor, who is ably represented here by the DVC Research, Innovation and Development, Professor Komi Ade Akinyemi. Thank you for coming, sir. Then our mama, the former DVC academics for the OAU, Emeritus Professor Mrs. Bickerstead. Thank you, ma, for coming. You're always an inspiration to every one of us. The Provost of Postgraduate College, who is able represented here by Deputy Provost, Professor Koji. Thank you for coming. Our former Provost and former VC of my own state university, Professor, thank you, sir, for being here. The Director of Public Health, Institute of Public Health, Professor Isima, and our distinguished lecturers who have traveled all the way from Abuja and Lagos, and the spouseman, thank you for being here. Our distinguished professors in the house and all invited guests, distinguished ladies and gentlemen, our students that are here this morning, I welcome you all. It's my great pleasure to extend warm felicitations to the Institute of Public Health of Obafemi Awolowo University on the occasion of this year's Lucas Memorial Lecture. I commend the Institute for sustaining this important academic tradition and for selecting a team that speaks directly to one of the most urgent needs in global and national health system, turning evidence into action, the role of implementation research in policy and practice. In a world increasingly shaped by complex health challenges, emerging infectious diseases, health inequalities, system inefficiencies, and resource constraints, evidence alone is no longer enough. What determines progress in our ability to translate research findings into feasible, context-appropriate, and sustainable actions. Implementation research plays a pivotal role in bridging the persistent gap between knowledge and practice, helping policymakers and practitioners make informed decisions that truly impacts population health. As a college, we remain committed to fostering a robust culture of inquiry, innovation, and practical relevance in health science, education, and research. The work of the Institute of the Public Health continues to strengthen this vision by producing research that not only advances knowledge, but also guides real-world intervention that improves lives. I urge all participants, academic students, policymakers, practitioners, and partners here today to seize this opportunity this lecture offers for us all. And to engage deeply with insights that we share and reflect on their implications for our health system and consider how we might work together to build stronger pathways for translating evidence into meaningful action. I commend the Institute of Public Health inspire generations of scholars and practitioners. On behalf of the College of Health Sciences, I wish you all a productive and enriching lectures. We have lectures. May today's deliberations spark ideas and collaboration that will advance health outcomes locally, nationally, and globally. I thank you all for being here. Thank you.
Thank you very much. Please let's give the provost another round of applause. All right, thank you. Okay, now we're moving on, and now I'd like to welcome the opening address by the chairman of this occasion. That is the Vice Chancellor, ably represented by the DVC Research, Innovations, and Development, in person of Professor Akoni Akinyemi. Please let us welcome Professor Akinyemi. Thank you very much.
Thank you, sir. Let me first sincerely appreciate God for another opportunity that we are gathered, under this platform that started, I think, 14 years ago. We sincerely want to thank God that this has been sustained, and for God to grant all those who have invited journey mercies, particularly with this Nigeria Express Road, without any bump. So we sincerely want to thank God for that. I bring greetings from the Vice Chancellor. It's not too far away. It's in the next building there, but he's sharing another meeting. So he has asked me to bring his greetings and to sincerely apologize for his inability. Artificial intelligence is not yet advanced that it can be in two places at the same time. But hopefully, as science continues to expand, I think that will happen. So I bring special greetings from the Vice Chancellors. Let me sincerely appreciate our Emeritus Professor, Professor Funmi Togonu Bike State. Thank you so much, man. For those who want to become an Emeritus Professor, I think you can clap better. Thank you so much, man. I think this week alone, last week, we invited you to campus twice, and she's very prompt and stayed all through. The Lord will continue to strengthen you for us, man. Thank you so much, man, for all you do. Special appreciation to the provost of Postgraduate College, ably represented by my brother, Professor Konji. Thank you so much. And the provost of College of Earth Sciences, Professor Benis Adegbengbe. Thank you so much, man. I know there are so many deans here, but I only saw the Dean of Basic Clinical Sciences, Professor Bodeni. Thank you, sir. I think I saw my friend before, Professor Adeyemi. Okay. Dean of Basic Medical Sciences. I don't know if there are other deans here. And to the host, the Director of the Institute of Public Health, Professor Puju Esime. Thank you so much. And to our distinguished speakers of today, Professor Olumide Ogundanzi. Thank you, sir. Yes, and my sister there, Dr. Shola Oresonya. Thank you so much. Yes. Greetings to all the professors and all our lecturers who are here, and also to all of our students, postgraduates and undergraduates who are here to listen. And also, I don't know if there's any family of Professor Lucas who is here. Not yet, okay. Please permit me to specially recognize my own mentor who is here. That's why I kept him last, in person of Professor Adesegun Fatusi. And I think you should be proud of yourself, sir. I mean, seeing that this seed has continued to grow and grow. I made this remark at the Faculty of Dentistry, I think that was last week, that we continue to learn from the College of Health Sciences, particularly for sustaining good legacies. God will continue to strengthen our directors and the directors coming yet. I mean, good legacies have to be sustained, So we want to sincerely thank you. I don't know if your wife is here, sir. Okay. Okay. Please, if you are the wife of Professor Fatusi, can we see your answer? Sorry. Yeah, we cannot see your hand. Thank you so much, man. Yes, thank you so much, man. Professor Ms. Fatusi. I need to especially thank her, and not just because she's the wife of Professor Fatusi. When I came on board as the Executive Director of Research, one of those very strong areas we are looking at is about the University Ethical Board. We needed to have a very strong University Ethical Board. So I spoke with many people, but I did not speak with Professor Adesegun Fatusi. I don't want to put you in trouble that I talk to you. So, just say if you can talk to her, if she accepts to do it, that she will do it well. But she will not agree because she's so busy. So then I went on fasting and prayer. And I talked to her. And God answered our prayers. So thank you so much, man. We sincerely want to appreciate you for all that you do. So the university now has a very strong ethical board, centrally headed by Professor Mrs. Fatusi. So please permit me, therefore, to go to the Vice Chancellor's remark for today. It's a privilege to welcome you to the 2025 annual Adetokunbo Lucas Public Health Leadership Lecture. This annual event honors the life and the legacies of Professor Adetokunbo Lucas, an eminent figure in global public health, whose commitment to excellence, equity, and evidence-based policy has had lasting impact on health systems across the world. The theme of this year's lecture, Turning Evidence into Action, the role of implementation research in policy and practice, is highly relevant. While evidence generation has advanced rapidly, our most important gains in health remains dependent on how well we deliver what is already known to work. Implementation research provides the tool to understand not just what works, but how to make it work within the real-world challenges of health system. Today, we are honored to have two distinguished guest speakers. As the MC rightly mentioned, who are also one of us, both of whom are proud alumni of Obafemi Awolowo University, to deliver this year's lecture. I think you will clap for them. Thank you so much, sir. Thank you so much, ma. Professor Olumide Ogundahunsi is an accomplished scholar with outstanding international career with the World Health Organization Special Program for Research and Training in Tropical Disease. Today, we are going to learn a lot, from his experience. And I think we've started our own talk, sir. And I think you have given approval. Thank you so much, sir. God, we want to bring him back to the university. Thank you for accepting, sir. I did not hear you, sir. Thank you, sir. And also Dr. Olushola Oresanya, who is a graduate of our College of Health Sciences, who currently serves as a Senior Technical Advisor for Operations and Implementation Research at Malaria Consortium. Thank you so much, man. We are proud that both speakers are from our university, not only as scholars, but as practitioners who have shaped health system functions. As an institution, Obafemi Awolowo University continues to advance knowledge in implementation research and public health system improvement. Special thanks to the Institute of Public Health for actively engaging in research, evaluation, and policy translation across all critical health indicators, including malaria control, reproductive and maternal health, health financing, and immunization. Please, let's clap for the Institute of Public Health. I commend the Institute of Public Health for convening today's important lecture and for sustaining this legacy that we continue to shape in our understanding of how to turn evidence into real measurable outcomes for population health. So on behalf of the Vice Chancellor, Professor Adebayo Simeon Bamire, who also double as the chairman of this occasion, I wish to formally declare the 2025 annual Adetokunbo Lucas Public Lecture open. Thank you and God bless.
Thank you very much for your kind words. We are very grateful, and we are glad that the flag keeps on flying. All right. Sometimes when I hold the mic, I'm tempted to say, praise God, hallelujah. In case it escapes, please just bear with me. All right. Now, we want to take some, right, so I'd like to recognize a few other people who are with us quickly. First, the former director of the Center for Gender Studies in the person of Professor Banjo. How are you, ma? You're welcome. Thank you very much. You're welcome. Okay, so we want to take some goodwill messages. I would like to start with the provost of the postgraduate college, represented by Professor Konji, to give a goodwill message. Thank you very much, sir.
Yes, I want to present the goodwill message on behalf of the provost, Postgraduate College of Bafumalo University, personal Professor A.O. Elesomi, who is presently representing the university also somewhere else. Please permit me, as I stand on the existing protocol. He said, and I read so, I bring warm greetings and goodwill on behalf of the Postgraduate College of Bafumalo University, Ile-Ife, Nigeria, on the occasion of this important public health lecture titled Turning Evidence into Action, the Role of Implementation Research in Policy and Practice. The theme is both timely and relevant, especially as a university and health institution increasingly seek ways to ensure that research and its outcome translate into meaningful societal impact in a world where knowledge expands rapidly. Evidence alone is not enough. What truly makes the difference is our collective ability to translate that evidence into meaningful, measurable action. Implementation research stands at the heart of this transition, bridging the gap between discovery and real-world impact, between policy formulation and practical change. The postgraduate college places high value on scholarship that addresses real-world challenges, and today's discourse further reinforces our commitment to promoting research that is actionable, sustainable, and aligned with national and global health priorities. We commend the Institute of Public Health for creating this platform for dialogue, collaboration, and knowledge exchange. It is through gathering like this that we strengthen our capacity to make informed decisions, improve system, and deliver better outcome for our communities. On behalf of the provost, I wish all participants an insightful and productive lecture. May the ideas shared today inspire stronger partnership, deeper inquiry, and evidence-driven practices that advance public health in our university and beyond. Thank you.
Thank you very much, sir. We are very grateful. Thank you very much. So very quickly, I'd like to call the Dean of the Faculty of Basic Clinical Sciences, Professor Abodere, for a goodwill message. Thank you very much. Please, let's give him a round of applause.
Thank you very much. And just like the PG College has done, I think the protocol will be well established and so that remains intact. And I was looking at the program and said, oh, so there's supposed to be a good message that I didn't know. But I also look over the years because I've been part of the story of Institute of Public Health. And so I said, okay, I can then go from what it used to be when I was just a lecturer and coordinating one of the units in Institute of Public Health. And now it has grown to this point. So that not only in those days when I think there were 3 units, pathobiology and infectious diseases, of which I coordinate then, just as a lecturer. Now my faculty is also part of the board of the Institute of Public Health. Now this annual lecture has come to stay, and I remember a particular year I helped facilitate bringing the Director General of Nigeria Center for Disease Control, Professor Nasidi, that came here, to the fact that this is the first public health institute within a university system. So I think this is also setting the pace for others like that in the country. Now that we're talking about implementation research, so as to be able to see how we can use evidence and contextualize evidence and make sure that it works. So I can see the progress, and I can only wish that we'll continue to set the pace as we go forward, and that we'll have a good time together today. Thank you.
Thank you very much. All right, before I call for some other good messages, I'd like to recognize our students from the School of Health Information Management. Please, let's give them a round of applause. Thank you, you're welcome. Also from the School of the Community Health Officers, you're welcome. Thank you very much. Please, let's give us a round of applause. Thank you very much. All right, I'd like to invite our special guest today, and that's the person of the Emeritus Professor Togodun Piquet-Stet, to give a goodwill message. I know Mama will query me today, but please bear with me, Ma. Please let's give her a round of applause, please.
To start with, as a joke, I don't want to stand on existing protocol so it doesn't collapse. Everybody stands on it, so I'm not standing on it, but I'm saying all those on the high table, good morning, and glad to have you here. And everybody here, you are very important. Thank you for coming, because you are spending your time. Your time is part of your destiny. So you're investing part of your destiny in this occasion. So I thank you. When Professor Esimai called me yesterday and said that they were having this today and would like me to come, I then reflected that I had not physically met the person being celebrated. But I'll tell you an event that happened years ago. I was here in Nigeria. I got a call from Rockefeller Foundation in the US that they have a major project from Nigeria and that they would want me to come over to New York to evaluate it. I wasn't even a professor. I got there to find that was a major project being done by Professor Lucas or something on public health. I'm not a doctor. I'm not a professor. But they wanted somebody who lives in Nigeria. And that ties it to what we're doing today. How do you make research useful, actionable? And the problem we have in the country is that there's hardly any problem in this country that we don't have research on. But you know where the research reports are? So what we're doing today is very, 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 it's very, very important. And I wish the faculty, the institute, the very best. It's an opportunity to reflect and to think about how we can do things better so that whatever we do becomes useful, actionable, and implementable. Thank you very much. God bless you.
Thank you very much. Please, let's give Mama another round of applause. Thank you very much. Can I hear the erudite speech, even though it's just for a brief moment. Thank you very much. Retired but not tired, Emeritus Professor. Thank you, ma'am. All right, finally, for the final goodwill message, on behalf of the Lucas family, I'd like to invite Professor Adesegun Fatusi. Thank you very much.
Thank you very much, everyone. And let me, Mama said she's not having protocol. I would like to abide with the protocol that has been well laid. But that says, I think it's important to recognize and to salute our able Vice Chancellor, represented here by a brother, a friend, a colleague, and a very dynamic researcher himself, Professor Kwana Akinyemi. Let me also quickly recognize our Mama. When people, it's amazing how time flies. I was just reflecting, just a couple of years ago, she was here leading us. I'm glad that you are still here, ma. And we pray that the Lord will continue to sustain you. I recognize my provost, I recognize the director and everyone. Permit me to start by just recognizing somebody online. You probably wonder why. I have online Dr. Maureen Malouani from the Hebrew University Adasa, from the Brown School of Public Health. You wonder also what happened. Why is this? Yesterday, she's the coordinator of the alumni group there. They're planning a program in Nigeria. So yesterday we were chatting, and our Professor Gunda was who is a friend and a brother. Shola Resa is one of my aburos, mentees, colleague, and many other things. And I said she wanted me to make a comment to Professor Gunda. So I said, oh, I'll see him today. He's going to be here to give Lucas lecture. So she wrote back to me, and I would like to read that, and I'm sure she's hearing me online. She said, good morning, and many thanks. I so wish I was there to hear Professor Olumide Ogundansi and to honor Professor Lucas' contributions and memory. A little guilt on that one. Maureen, I didn't ask for your permission. I'm sure I have you to read this. He said, a little guilt on that one. I have my unfinished article on TDR and my interview with him framed within the TDR's work on leishmaniasis, sitting in my file. Professor Lucas was the director who saved TDR from itself, or at least his former director. End of quote. And with that, I'd like to say that it's a great pleasure to stand on behalf of Lucas family this morning. And my mind went back to the first time we met Professor Lucas, when we wanted to start this. I never met him. And we just decided we are starting this within, I think I was making a director on 1st of August. So we said we are going to start this and start it in the name of somebody everybody can recognize. And that's how we went to Baba, and Baba agreed. And he did not only agree to that lecture, but he took all of us who are part of the leadership as members of his family. Akade Jadola, my wife, and we became part of the Lucas family. So I'm glad this morning to stand on behalf of that family. And the family truly, and everyone who had been here long enough, knows that the family truly celebrates this moment and eternally grateful that the university and the Institute of Public Health has continued to maintain this great momentum of this lecture. Many times, the family will come in large number and celebrate. One of the things I cannot do on behalf of the family is to sing the family song because I don't know how to sing. But if they have been here, they will have sung the song. Our Lucas, So the family is so proud of this event, and so particularly thankful that even despite Papa's having gone for a number of years, that momentum has not only been kept, the frontiers of the activities has been expanded. And now it's not just lecture, there are outreaches and things like that. So the family is grateful to the director and the leadership of the institute, and indeed the leadership of the university. If Papa had been here in person today, what would he have said? I tell you one thing I think he will have said. He will have said, it is not just about evidence, but that evidence must translate to action. And it will give you a practical experience. He will say, if you are talking about evidence, you need to monitor and you need to evaluate things. And that to monitor is like a housewife who is cooking. That's the exact thing we'll have to do. And when the woman is cooking and puts salt and put pepper, and she puts in her hand and leaks, that is monitoring. And at the end of the cooking, when he puts it in a plate to sit down with the family to eat, and he asks the husband, how does it taste? And he says it tastes well. That's the evaluation. Again, I want to thank you on behalf of Lucas family. God bless us.
Thank you very much. Indeed, that is what Baba Lucas will have said, because he always has a joke for every occasion. Thank you very much, sir. All right, so we are moving forward. We're going to be going very quickly to the time where we're gathered. We're not, the message from Mama Lucas is not available, so we won't be playing that today. But we're going to the next item on the agenda, and that is the reading of the citation of our guest lecturer, the first guest lecturer. That is the person of Professor Olumide Ogundaunsi. I will invite Professor Olumide Ogundaunsi to please come forward towards the podium, and I would like you to please welcome with me Professor Titi. Okay, I'm giving everybody professor today. Okay, time is coming. Dr. Titi Adeyanju, who is a consultant, public health physician, and she will be reading the citation of Professor Olumide Ogundaunsi. Thank you very much.
Good morning, sirs and ma'ams. Please permit me to stand on the already well laid down protocol as I introduce to you the speaker for today in the person of Professor Olumide Ogundaunsi. Professor Ogundaunsi is a distinguished leader in public health, renowned for extensive work in global health and implementation research. With a background in pharmacology and therapeutics, he seamlessly transitioned to public health and implementation research for optimal access to and delivery of health interventions, especially in low and middle income countries. His professional career spans 4 decades in academia, research, public health, and international diplomacy. He was born in Lagos and educated at Igbobi College, Lagos, University of Ibadan, Obafemi Awolowo University, Ile-Ife, Nigeria, and the Oregon Health Sciences University, Portland, Oregon, USA. He obtained a doctorate in pharmacology at the University of Ibadan, following a thesis on anti-malaria drug resistance and establishment of the first facility for continuous cultivation and drug susceptibility testing of Plasmodium falciparum in West Africa. Between 1983 and 2000, he lectured pharmacology, therapeutics, and toxicology at the Obafemi Awolowo University, Ile-Ife, the Olabisi Onabanjo University, Ago-Iwoye, and the University of Ibadan. In 2000, he left the University of Ibadan following his appointment as scientist in the special program for research and training in tropical diseases at the World Health Organization headquarters in Geneva, where he was responsible for negotiating the managing partnerships with global research organizations, national governments, and United Nations agencies as the senior staff in the diplomatic cadre of the World Health Organization's headquarters in Geneva. From 2000 to 2020, he managed several research grant portfolios at the World Health Organization, addressing issues related to malaria in Africa and research capacity in low and middle income countries. He worked to build and promote partnerships with academic research institutions in developing countries, international research consortia, and government agencies. He oversaw a multidisciplinary portfolio of research and training grants and initiated a novel postgraduate training scheme in 7 faculties of public health in universities across Africa, Asia, South America, and Middle East, with a focus on implementation research to address barriers to quality healthcare. Dr. Ogundaunsi also led a strategic partnership with the United Nations Development Program, UNDP, PATH, and the WHO to strengthen the capacities of low and middle income countries for optimal access to and delivery of new health technologies. He is co-author and editor of the WHO Implementation Research Toolkit and has contributed significantly to the recognition of implementation research as an essential tool for the optimization of health programs, interventions, and strategies. In 2018, he joined University of Medical Sciences, Ondo, as adjunct staff and professor in the Department of Pharmacology and Therapeutics, and subsequently opted for early retirement from the WHO in 2020 to return to Nigeria and fully commit to the University of Medical Sciences, Ondo. At Unimed Ondo, he was the director in the Central Office for Research and Development and professor in the Department of Pharmacology and Therapeutics, and subsequently the Director of Strategy and Program Development until he resigned his appointment in April 2025 to allow him to better focus on national and continental activities aligned with his current altruistic aspirations. Professor Ogundaunsi has held various advisory roles with national and international health organizations, contributing significantly to strategies for health, equity, and sustainable development. He serves on several boards of trustees, including the Health Policy Watch, Geneva, Switzerland, Oluwakikugbe Pharmacy Education Trust, Population Services International, Nigeria, and the Feet of Grace Foundation, which is an NGO focused on providing prosthetics, limbs to amputees, especially women and children. He is also member of the Management and Scientific Advisory Board of several international research consortia, including SAVIN, an EU-funded consortium addressing on sustainable access to vaccines in Ghana, and the Malaria Research and Capacity Development Consortium, which is a consortium funded by the Wellcome Trust, Deltas, and covering West and Central Africa, and the Pan-African Malaria Genetic Epidemiology Network, a Wellcome Trust Delta consortium examining human, parasite, and vector genomic data from 7 locations distributed across the continent. He has received international recognition for his contribution to strengthening research capacity in Africa during the 7th MIM Pan-African Malaria Conference, Dakar 2018, and the Ogobara Dombo Award for Lifetime Achievements in Malaria Research and Capacity Building in 2024. He has served on the scientific and technical advisory boards of the South African Malaria Initiative, Malaria Research Reference Reagents Resource, MR4, Virginia, USA, and Coalition for Health Campaign Effectiveness, and chaired the Scientific Review Committee, EDCTP, Clinical Trials, Capacity Building, Networking Call for Evaluating the Impact of Clinical Trials in Africa. He was guest editor, Acta Tropica, special issue on malaria research in Africa, and on the editorial team of Parasite Epidemiology and Control, a journal of the World Federation of Parasitologists. Professor Ogundaunsi has dedicated his career to translating scientific evidence into impactful health programs and policies, particularly in resource-constrained settings. His work focuses on understanding the complex interplay between health systems, communities, and policy frameworks to optimize the delivery of interventions. Distinguished ladies and gentlemen, I would like us to please rise and welcome with me Professor Olumide Ogundaunsi as he delivers his lecture. Thank you very much.
Thank you very much. Please have your seats. I'd like to also begin by recognizing all the persons on the high table. Without going into the details of each of you specifically, I'd also like to recognize all the deans and professors who are seated here in the hall. When I was invited to give this lecture, I had a little bit of a debate within myself as to whether I should do a deep dive into implementation research or deliver a lecture that generally honors the memory and legacy of Professor Lucas. Definitely, I chose not to do a deep dive, but I'll leave it to you to make a judgment as to if I've done justice to Professor Lucas's memory or not. By the way, the title of the lecture, which you have in the program, is slightly different from, well, not slightly different, quite different from what I'll be speaking on. I will be speaking on what I've titled the Parallel Universes of Research, Policy, and Implementation, Bridging the Divide with Implementation Research. Okay, I need to figure out how this works now. Okay. So by way of introduction, this divide, the way I see it, between research, policy, and implementation has been a very persistent one and has been in existence for a very long time. And from what I know of Professor Lucas, as I'll talk about in a short while, he left a significant mark on global health. And this impact, this mark which he left was driven, as we have heard, by his strong commitment to turning research findings into practical solutions. And despite the efforts that we've had over the years, this challenge remains. It persists, and essentially what we see is what has been referred to by some people as a gap between what you find in research and what happens in the real life setting. So very often research, policy, and implementation, they operate in separate spheres with very, very little overlap between them. Okay. I'll just pause while those on the high table move to the front row so that they can get a better view of the slides. That's okay. I think it's better this way so that we don't need to do some physio after the lecture because people haven't spent their necks. So this is a favorite slide of mine that shows what that divide really looks like. A lot of work is going into research and development, the so-called R&D pipeline. And then at the end of the pipeline, a product comes out. But now how to get that product into society and get it in there for effective use becomes a challenge. And these are some of the things that Professor Lucas had talked about and had tried to address in the course of his career and time with us. So let's talk about Professor Lucas a little bit. Professor Lucas in his time was very, very widely recognized as one of the world's leading tropical disease experts. And over that period, he blazed new pathways in academic and international leadership, in clinical medicine, public health, and global health policy in general. He was very versatile. He was the first head of department of community medicine in Ibadan. was also, as we've heard, one of the pivotal directors. He was the second director of the Tropical Disease Research Program in WHO, but really he was the actually considered the first director, because it was during his time that department was rescued and began to do impactful things. So he was considered by many as the pioneering director of the TDR department in WHO, TDR program in WHO. And while he was there, he developed novel therapy for many parasitic diseases, leishmaniasis, malaria, schistosomiasis, several of them. And some of those therapies and approaches are still being in use today. Also, he also helped and encouraged new approaches to social, economic, and epidemiological research as far as these diseases were concerned. He was clearly a visionary global health expert. One of the things that he also pioneered was the public-private partnership that we see quite a bit of in the health sector today. So he initiated the public-private partnership with Merck Corporation to make ivermectin available for the treatment of river blindness. Ivermectin had been developed as a veterinary medication, and Merck had made tons of money from it from veterinary practice. You know, in the Western world, in Europe and North America in particular, they love their dogs. And, you know, sometimes if you know the amount of money they spend on veterinary care, you would just be amazed. And so Merck made plenty of money from this, and this drug was just there. They had, you know, recouped their R&D investment on it, and he was able to convince Merck to make a donation of ivermectin produced very cheaply to the, you know, to the health community for the treatment of a disease that was plaguing most of river blindness. He also launched the Prevention of Maternal Mortality program. And on a personal level, and I can say this because as you will see in a short while, I had a good fortune of meeting him. Professor Lucas was a delightful human being. He had an infectious sense of humor. You couldn't stay with him without ending up laughing, or at the very least, smiling broadly. He had a great ability to tell the right humorous story at the right time, and jokes that were just appropriate for the occasion. So I did have the fortune of meeting him. And a scripture in Job kind of, I will say, it's a very apt description of my encounter with Professor Lucas. You know, Job 42 verse 5 says, I've only heard about you before, but now I've seen you with my eyes. So in 1981, as a young undergraduate, I was about finishing my graduate degree then, and I was working on a research project looking at the pharmacokinetics of chloroquine. And I got to know about Professor Lucas because that project was funded by a WHO TDR grant. And Professor Lucas was director of TDR at that time. Professor Salako, the lead Professor Latif Salako, who was my head of department at that time, had received this grant from WTDR, and it was very important that the work was properly done because it was this Nigerian who had this big position in WHO, and if, you know, this Nigerian university didn't deliver, it will look bad, and it will, you know, create very bad image for this Nigerian. It was done right, and we did the work. And as God will have it, 19 years later, in the year 2000, when I'd moved over to begin to work in Geneva, I was working in the very same program where he was director of the TDR, and I had the good fortune of meeting him, not as TDR director, but, you know, somebody who was, I think at that time was either at Carnegie or Harvard, but he came around and he needed to get something done, and somebody, I was introduced to him by another professor of statistics, Professor Ayeni, and I was just in awe that, oh wow, this is the Professor Lucas. But then, you know, he has this very, very disarming personality. And even though he was much older, very, very accomplished, very senior person, as a young man then, you know, he put me very, very much at ease. And what did he want? What did he need? He needed me to help him repair a Movado wristwatch. And that's why that wristwatch is there. He was, you know, he was passing through Geneva, but there was a company in Geneva that could repair the watch for him. It was a very precious watch to him. I think it had been given to him as a memento from one of the places where he worked. And there was something wrong with one of the dials, which was made of, I think, 18 karat gold. So he just didn't want to give it to anybody or any horologist to repair. And he found me, and I said to myself, this man doesn't know me. He only knows I'm a Nigerian and in this place, and he gave me this wristwatch. And that was supposed to look out for you. So I did have the good fortune of meeting him, and I can testify that everything that has been said about him is true. His personality, the dedication to public health, and the kind of quality that he promoted, you know, over time while he was with us. So I title this lecture around the disconnect between the parallel universes of research, policy, and implementation. And I just have this slide up there just to illustrate what I mean by this. How scientific decision-making, which usually is around research, you look at a problem, identify it, then you develop a hypothesis, you do the study, you plan the study, you do the study, you analyze the data, and you publish the results. And then, you know, that's how, you know, science operates. And those results are in publications, high impact factor journals or whatever, but, you know, they're published. The politicians and the people who make decisions around policy, they operate, you know, differently. They also identify problems, but they make a political judgment. They build support, look for stakeholders, and look for people who believe in the decision that they have made, and they propose a new initiative. They look for how people react to their initiative, and if it's positive, they assign resources, and, you know, the cycle goes on. But the communication between the disciplines, there's a two-way process, but this middle portion here, including the synthesis of ideas from multiple studies, is not optimized, and that is a divide that I am referring to. So, essentially, what we see is multiple spheres of operation where each one is self-contained. They operate independently and often by different rules. And the main challenge is that researchers, policymakers, and implementers, you know, operate in their own cocoon, and communication and collaboration between them is not effective, and this ultimately affects progress and delivery of services. And so, while public policy can and does influence and shape health outcomes, robust scientific evidence often fail, as we have heard this morning, to translate into effective implementation or effective policy. It's not as if the policy is not there, but the policy is not effective. And the result is what we see as lack of collaboration, which will hinder effective public health outcomes. And one of the examples that I like to give is around nutrition programs, not because my wife is a nutritionist, but, you know, it's something that I found, you know, quite practical, where you design a nutrition initiative for communities without engaging the communities, and this ultimately will result either in failure or in low participation. For example, you have a situation where you have a predominantly Muslim community that has a nutrition problem. Access to protein is limited. And because you have resources or someone has decided to supply, let's say, ham, meat from pigs, and it is meat, it is protein, but it's not appropriate for that community. But you didn't engage them to know what kind of meat they would need or they will consume. Of course, that will not go anywhere, it will not gain any traction. And so these are the kind of things that happen when you don't have this kind of engagement and ask the right implementation questions before you begin to deploy an intervention. So essentially what you see, and this example that I have here is generally from malaria, where you had an efficacious tool or policy. But then because of issues around access to that intervention, compliance by the provider, supply chain, adherence by the patients, the impacts will drop from what you would have had at this level to something low here. So it's at each point in time, there's a drop in the impact. A poor access will reduce impact. Poor provider compliance will reduce impact. Poor patient adherence will reduce impact. And so an understanding of what's happening around each of these will make a difference in how much impact you have in that intervention when you deliver when it is delivered. And so implementation research provides a critical systematic approach to addressing this kind of problems. It helps to understand and address barriers that prevent effective health intervention from reaching their full potential in real-world settings. And that's, as you will see later on, that's where implementation research is different. It is conducted not in the sterile clinical environment of laboratories or controlled trials. It is conducted in real-world settings. You don't change anything. You observe and deliver the intervention as it will be delivered in real life. People go to markets, traffic, situations happen. Government doesn't have all the resources. Health workers are inadequate. That is the real world setting. And so you try and understand what the problems are. And the aim is to optimize the intervention for better health outcomes by linking explicitly the evidence that you have with practical application. And the practical application there means that you are looking at how that thing would work when you deploy it in real life outside the environment of a situation where you're trying to do research for a publication or write a paper, as the case may be. So again, IR, implementation research, is this bridge that links the research with the policy, with the implementation or the delivery of the intervention. To get the research to drive the policy, there has to be a link. And then to get the policy effectively implemented, there has to be a link. So IR, or implementation research, serves as that crucial link, and it links evidence to practical applications for better health outcomes. Now, some of the key focus of IR, at the risk of repeating myself again, is connecting research to practical application. But the premise for this is identifying the obstacles and enablers for that implementation. That's identifying what the problems are, the bottlenecks, the challenges, the barriers, and the things that you need to do to put in place to enhance it. And then testing strategies to improve the delivery of this intervention. So in my quote unquote, well, in the first few years, or the first third of my career, if I can put it that way, the first 1/3 of my career, I was essentially a clinical pharmacologist, basic pharmacologist. I didn't do any thing around implementation research. But in the second part of my career, if I may digress, I had the opportunity to be involved in a much more broader, in a much wider field. I was exposed to a wider range of research and research issues around. I was working on malaria at a much more global level, and worked on things around the home management of malaria, developing rectal artesunate as an intervention for malaria. I managed a portfolio of grants that cut across different aspects, socioeconomic, entomology, and all of that. And I also had to engage with malaria control programs in the countries. When I was in academia, in the university, the engagement with control programs was very limited. I did my research, looked at drug resistance, published it, and that was it. But subsequently, I had to engage with the malaria control program and began to ask the questions that, but this research was done by so and so and so. Why are you not factoring it in to your processes and policies and all of that? Or some of the research that was done, it takes a long time for it to find its way into influencing policy. And my eyes, got open to a number of things that really there was a disconnect between what the scientists are doing, what the policymakers are thinking, and what the implementers are experiencing in the field. So that's ultimately, again, because of certain changes that were happening in WHO at that time, made me to learn a bit more about this, and ultimately we ended up working to develop the implementation research toolkit. Initially, it was supposed to be an implementation research curriculum, and this was what was being promoted by the development agencies at that time who were working with. But I thought that having come from the university system, you don't just do curriculum and give it to university and say, this is the curriculum. No, universities don't run that way. So something that had a much more broader application was probably made a bit more sense. And so we looked at developing the toolkit, which contained different modules to address different matters, but I will not delve too much into that. But in the course of doing this work, I'll talk about a number of things that again, became highlighted. And that are the fundamental differences between these three sets of persons: researchers, policymakers, and implementers. The decision-making processes, the incentives, the priorities, and timelines are very different. While the researchers will focus on scientific rigor, they are happy with doing long-term studies as long as they have the funding, and the discussions of their studies, can be quite nuanced. It's not that it may not necessarily be direct, and they are looking at confidence intervals and figures and statistics and significant difference and all the rest of them. Policymakers, on the other hand, focus on things like re-election cycles. Well, what they are doing, will it have an impact in the community for them to say, oh, these people, when they were in government, when they were in power, they did X, Y, Z for us, and so let's vote for them. So they're looking at that. They're looking at short-term needs. While, as a scientist, researcher, you're looking at a story that will, span over a period of 3-4 years. I mean, if you have a funding for 5 years, is it good? Is it not? Yeah. So if they're doing a funding for 5 years, that's fine. But the policymaker doesn't want, to do a study for 5 years, after which, his term would have been over and have been looking for re-election. So it's a complete different mindset. Their judgments are based very often on politics and political expediencies. They have other considerations, including things around equity, which of course scientists always should look at, but they even more because it has an impact on their acceptability. And they're looking at more definitive language. There's no nuance about, about them. So they're looking at what do you estimate will be the difference if I do or put in place this particular intervention. Implementers, on the other hand, they are the end of the line. They are the one that face the real life challenges. They are the ones that have to deal with no diesel in generator. I was at a meeting of the Nigerian Society of Anesthesia last week, and somebody was talking there about when you're doing surgery, you have to make sure before, apart from your regular checklists of instruments and the things you need, you also have to add to your checklist diesel and somebody who will also be there to return on. And then the duration of your surgery is also directly correlated with how long the generator can work. So I mean, this is how mentors deal with the real life challenges. Health workers are not adequate. A number of them have emigrated. Training is not adequate. Skills are not always what you expect them to be. So issues around resources, human and financial, issues around infrastructure, and sometimes also issues around culture, as you will see later on. One of the things that made the polio vaccination program eventually gain traction in northern Nigeria was because the implementers and the program and eventually engaged the imams, the clerics, and traditional rulers what the outcomes are. And then barrier is overlooked. So what is the bottom line? What is really how to approach that place kind of barrier? So the biggest, one of the biggest challenges is that the research that is often done is not demand driven. What would I mean by that? So the researchers go on to do literature, come up with ideas, what they think are the issues, and they plan to study around it. They put together a proposal to address that very sound, logical, the hypothesis is good, get funding source. But for the implementers and the policymakers, that is not their priority. there was no engagement with them before this idea was put together. So when you come up with the finding of that research, it will sit in some shelf, it will be cited for promotion, all of that. But then, because it's not addressing the need from the policymakers, from the implementers, they are not likely to use it because it is not relevant. It's not relevant to their need at that point in time. So that again is a challenge that we see that ends up creating a barrier. And along, of course, with all the other issues around infrastructure, which affects implementation, regulatory barriers, which affect implementation. For example, there's a drug that's been recommended, as first line, but then policy creates a barrier because there's a disconnect between the policy from the finance and the policy from the health sector. And so, for example, import duties that have to be paid to get that drug into the country so high that eventually creates a barrier to access of that drug and the population. Then sometimes the barrier could be around socioeconomic or cultural issues. Sometimes geography itself will be a barrier because that will affect how guys can get to the facility in a timely manner, or how they can get to the community in a timely manner. So geography itself could constitute a barrier. Is it coming on? Okay. And then behavior also behavioral. So this could also affect things around and motivation. So just to quickly go on, I spoke about this before, but real life setting must be demand driven, takes place in the real world. The thing about implementation research is also that it's dynamic and can be complex. You respond in real time. So essentially, because you are trying to solve a problem in a real life setting, the studies have to be designed in such a way that you can do course corrections or change approaches along the way. It's not artificial in any way whatsoever. There's always a feedback of the outcome of the research to determine what goes on subsequently. And again, very important, it involves multidisciplinary research teams. That's a key factor in this kind of on this kind of research, because there are various stakeholders that are involved in the whole process, in the delivery of the intervention, in the implementation of the policy. You have to engage everybody, so you have all the voices around the table, depending on what you're trying to address. So it's important to involve all stakeholders from the start, and also so they can look at issues around socioeconomic issues, cultural issues, political issues, and issues also around the health system. I talked about continuous monitoring and adaptation, but also equally important is the fact that your communication strategy has to be such that it doesn't just cater for the academic audience alone. So in implementation research, the knowledge outcomes goes beyond the publication in the peer-reviewed journal. And these are things that, the toolkit talks about the different kinds of publication communication approaches that you can use to get the information across the different groups that you would engage. So the outcomes are looking at outcomes with the clients, the patients, or the community you're working with. The service outcome in terms of the quality, efficiency, and equity. The implementation outcomes in terms of sustainability, accessibility, and all of that, and also the system outcome, how that can be sustained in the system in the long term. As I conclude, I just thought I should, because we are also in an academic setting, I thought I should bring this publication to our attention. It's written by a group of scientists who are, spread across Africa, but most of the authors are based at WITS in South Africa, even though a number of them are Nigerians. Was published in Lancet Global Health just a couple of months ago, I believe. And I thought it just illustrates the point, well, 2 points. First of all, that one cap does not fit all. And secondly, that the universities need to take an original approach in addressing IR. What does this paper say? But people are essentially saying that the frameworks for implementation research, which have been developed in Europe and North America, do not take into consideration the realities in Africa. And so when you apply them exactly as they are, been developed in those contexts, they do not drive successful implementation in reality in Africa. And they have a number of examples. I just put 3 of them up there. There was one from Nigeria where the framework failed to capture the importance of engaging leadership. I talked about stakeholders. Even the leadership, they're also part of the stakeholders. If you look at the toolkits, which I talked about, there isn't time to delve into all that detail now, but among the stakeholders includes, community leaders, opinion leaders, gatekeepers, those kind of people. The way society is structured in Africa is not exactly the same way it is structured in those contexts. And the frameworks don't consider those things because the systems, are there, the Department of Health or whatever, does what it needs to do. There's some civil servant who, does what needs to be done, and you don't need to engage and convince anybody and, get buy-in, to mobilize people. But it's very important. It was very important, in this study that was looked at in Nigeria. Culture also is another very important factor. Those things influence. I was talking about the case of polio program in northern Nigeria. It's very, very important that you factor in the culture. Also, other settings that extraneous, so-called quote unquote extraneous factors. It's also important to factor this in. So, for this reason, I thought that it's important that we as academics, universities, and researchers understand this and begin to pay more attention to the science of implementation in our institutions, as well as conducting implementation research. There's no doubt, everybody has come to agree now that what people thought was soft science before, implementation research, which, by the way, has always been done by commercial companies, Coca-Cola, all of them. They do IR. They call it market survey, but basically what they're doing is that they're finding out what their customers need, see how they can adapt their products to meet the customers' needs. And, when, I don't know how many people here know what SAP is or experience SAP. Experienced, the economic depression of the 80s. But it was then that, I don't know which IR the companies did, that's when they found out that if you actually began to package powdered milk and beverages in small single-use sachets, a lot more people will be able to afford it rather than buying the tin. In those days, it used to be just, the standard thing was to buy the tin. But they saw that the economic situation wasn't allowing people to purchase that. And then they did the research and found out how that worked. And then they changed. And so that was IR that they were doing. But we called it, people call it market research, but it's essentially IR. But anyway, there's agreement now that IR is important for getting research into policy and also making implementation much more efficient. But then, for us as public health leaders, I think, like Professor Lucas said, and as he always preached, our duty as public health professionals and academia must extend beyond discovery. It must extend beyond publications. It must extend beyond doing the research for our promotion or for the advancement, quote unquote, of knowledge, but also to see that knowledge translates into products that can improve health and well-being of the community. So beyond discovery, that scientific knowledge was applied to improve health, but also IR requires that we cultivate political champions and teams that go beyond our core expertise and disciplines to make sure that this is delivered in the right way. So there's no Lone Ranger research in IR. It's always done by a team. So finally, I will say that we must champion and engage in IR. It's one of the things that Professor Lucas talked about, even though it wasn't called IR at that time, that had gone through all kinds of, but the principle is the same. How do you get this intervention to the population? How does it make an impact? How does it make a difference? What is the value of this research we have done? How do we get people to use it? We also need to foster dialogue and embrace strategies that will turn evidence into action for a more equitable society. And I think finally, like I just said a few minutes ago, it's important that we strengthen capacity within the university system so that the universities can be the catalyst for driving implementation research in the country. You see, implementation research doesn't only involve university researchers, academic researchers, researchers in healthcare. No, it involves the implementers. It involves the the development agencies. It involves the policymakers. It involves the communities. It involves even the patients or the recipients. So we must, but universities should be the knowledge repository to channel this and to develop this as a domain, a very robust domain, within the country, so that our interventions can find value and use. So to do that, they must have the capacity both to teach and to conduct. And we cannot just depend on frameworks and ideas and concepts that have been developed outside our own context. But we should also see what would work and what will work best in our own context. I'd like to thank you all for spending time to listen for the past several minutes. And I do hope that you found this very useful. Thank you.
Thank you very much. Please let us give Professor Ogundausi another round of applause. I believe we took notes, and there are many things to take home there, but we're going to have a brief Q&A session for people to ask questions and perhaps give comments. So please reserve your questions till then. We are going to jump straight to the next guest lecture. And our second guest lecturer is no other person than Dr. Olushola Oresanya. I'd like to invite her to please come forward. At the same token, I'd like to invite Dr. Oluwaseun to read a citation. Please, welcome. Thank you very much. Dr. Eson is a consultant public health physician, Department of Community Health. Thank you very much. And a friend.
I like to present to you Dr. Olushola Oresanya. Dr. Olushola Oresanya is a public health specialist with a strong foundation in epidemiology and 24 years post-qualification experience as a medical doctor trained here at the Obafemi Awolowo University, Ile-Ife, and the Hebrew University, Israel. And she currently runs a doctorate program at the London School of Hygiene and Tropical Medicine in United Kingdom. She led Malaria Consortium's technical team in Nigeria for over a decade as the senior country technical coordinator, leveraging her expertise to not only design, implement, and evaluate malaria control strategies, but also to mentor, build capacity, and inspire the technical team in the organization. While in this role, she led the development and institutionalization of technical quality assurance systems and processes for project implementation, of her previous work include the creation and testing of a roadmap for integrated community case management of childhood illnesses, ICCM, in Nigeria, implementation of simplified tools for community management of severe acute malnutrition and chest indrawing, piloting, scale-up and digitization of seasonal malaria chemo prevention, insecticide-treated net campaigns, co-implementation of vitamin A supplementation with seasonal malaria chemo prevention, perennial malaria chemo prevention, malaria vaccine rollout, azithromycin mass drug administration, and digitization of campaigns, of malaria campaigns, among others. She's currently the Senior Technical Advisor, Operations and Implementation Research, a global role providing support at the organizational level to the development of Malaria Consortium's core competence in implementation science through technical leadership, technical contributions, technical oversight, and quality assurance, specifically in implementation research and operational research to ensure high quality outputs at all levels, program, country, and global. Our research interest is in implementation science, finding new ways of deploying existing life-saving interventions to achieve greater impact. Our other interests include youth development, leadership, mentoring, pastoring, preaching, and she enjoys praying, and she enjoys writing. She's a sweet person, a sweet friend of mine. I humbly present to you Dr. Olushola Oresanya. Thank you.
Thank you very much. I'm sure you added your own to it. It's such an honor to be here and such a privilege to be presenting a lecture at this very prestigious gathering in front of all my teachers, my lecturers. And I'm so privileged to be here. Thank you for this honor that you have given to me. I will be standing on the protocol that has already been established, but I want to also recognize Professor Emeritus. I'm so honored to have met you. Thank you for this privilege. And Professor Ogundaonsi has laid the foundation for what I'm going to be speaking on. And so I will just be bringing you practical examples of some of the things that we have done, riding on the learnings that the TDR has provided over the years. I'm a student of the massive open
online course on implementation science, and it's been such a tremendous blessing. So today I'm just going to be talking about turning evidence into action and taking case studies from Malaria Consortium. So I would also talk a little bit about our approach to implementation research, and also our status as an independent research organization. And then I will talk about 3 case studies. I hope time permits me to go through all those 3. And then share some of the lessons that we have learned in the course of implementing these projects, and then I would conclude. So by way of introduction, for those of us who are not so familiar with Malaria Consortium, we are a charity organization that is headquartered in the United Kingdom. We are registered with the UK government as a charity organization, and it's one of the leading non-profit organizations that is committed to the prevention and treatment of malaria, including diagnosis and treatment of malaria and other preventable diseases across Africa and Asia. We've been doing this now for over 20 years, and we certainly have learned a lot while doing that, and I'll be sharing some of our experiences with you. We have regional offices across Asia and Africa. We have 2 regional offices in Africa, in West and Central Africa, and the headquarters is in Nigeria. And then we have in East and Southern Africa, the headquarters is in Uganda. Our HQ is in the UK, as I mentioned, and then in Asia, our regional office is based in Thailand, and we are in 6 countries in Asia and 12 countries across Africa. So what is our approach to implementation research? Of course, here, Professor Ogundaunsi has gone into details about this. And just basically, it's a thematic approach. Effective, efficacious intervention becoming effective in a real world setting. So, and he talked about that decay that happens because of the many challenges in between an efficacious intervention, meaning an intervention that has been tested to be effective under research setting. But then when you put it in a real world setting, it looks as if it's not working. It's not because that intervention doesn't work, but because of many other issues that are within the context that the intervention has been dropped. And so it's looking at those issues and addressing them in order to ensure that that efficacious intervention has an impact in real world setting. So at Malaria Consortium, we believe that before an health intervention or a delivery strategy can be adopted or scaled up, they first need to be tested to determine whether it is feasible to implement that intervention, and whether it is acceptable to the community, and also whether it is cost effective within a given context. So pilot studies help us to confirm, the proof of concept, to check that when you think about something that this thing can work, and then you implement it and you see that really it can work in a research setting, in the laboratory it works. But then to now take it from the laboratory and put it in, a real environment, you need to check it, and you need a pilot, and it's a pilot that helps us to do that. So we use implementation science to understand what works, where, and why they work. And context is very important, as we have heard earlier, that something worked in a particular location does not necessarily mean that when you put it in another location, it will work. There's something we call transferability. You have to check whether the conditions that made this intervention to work in this place where it was documented to have worked are similar to the conditions that you have in the new setting that you want to implement that intervention. And so our approach is rooted in, asking practical questions as we implement in real world settings. And then we create, that continuous cycle of improvement. So as you implement, you find out that, in this area, the coverage of bed net that was distributed is lower in this area compared to another area. So you want to ask yourself, why are we not achieving high coverage in this area? Why are we achieving, higher coverage in this area? And you want to check what are the issues. And then once you ask yourself a research question, then you design an implementation research to answer that question in order to find strategies that can help you improve the uptake of bed nets. We also test new interventions or even the delivery, new ways of implementing existing interventions. So Malaria Consortium is also an independent research organization. What that means is that that's the status that is awarded to organizations that can demonstrate in-house capacity to carry out research. And it gives us the ability also to compete with universities or even collaborate with universities for grants to implement research. And we got into this status about 3 or 4 years ago, and we've been able to get research-specific grants to implement certain studies within the organization. And just to also show the scope of the kinds of research that we do in the organization, it includes formative evaluation up to operational and implementation research. We do randomized control trials. We also have we have an arm that looks at laboratory and field-based studies, impact studies, clinical and epidemiological studies, health services and health systems research, and so on and so forth. And so as an example, our seasonal malaria chemo prevention program is one program that has a very robust research component. So as both a leading implementer of seasonal malaria chemo prevention, and I'm going to talk a little bit about that and how we got into that, and a research organization, we are uniquely placed to build the body of evidence around, around SMC, seasonal malaria chemo prevention. And so our research focuses on, not only improving the quality of implementation, but it also focuses on looking at the future, already asking questions beyond the now, as it relates to seasonal malaria chemo prevention. So we ask questions around what is the optimum number of cycles, for instance, and because the epidemiology of malaria is changing, it keeps changing, and climate change also is contributing to that change. And so the areas that initially were having 4 months as their, the peak of transmission of malaria, we are seeing that there's an extension beyond that 4 months. Usually rainfall will happen in that area, especially in the Sahel, intensely over a period of 4 months, and then it will cease. But we are seeing an extension in those, in the duration of rainfall because of right now. Are they adequate, or do we need to review that? Do we need to extend the age and all that? And then also looking at the drug that is being used, looking at the platform that is being used to deliver the intervention and what can be used to optimize the platform. So some examples of our SMC research include the role model mothers approach that was used to strengthen administration of SMC across 3 countries. And then we also have conducted research around looking at the impact of SMC and also rapid assessments. WHO recommended seasonal malaria chemoprevention for areas where you have peak transmission that is limited to a certain number of months. However, we found that that is as much as it is located in the Sahel region, there are some other regions, some other countries where SMC has been found to be effective in the control of malaria. And so these rapid assessments were carried out in countries outside the Sahel, Mozambique, Malawi, to see whether there are areas within those countries that can be eligible for SMC. And such areas were identified and are currently implementing SMC. So I'd like to now talk about some examples of implementation research that we have conducted in Malaria Consortium that has moved from concept to scale. And one of them is the seasonal malaria chemoprevention that I started talking about. This intervention is a WHO recommended intervention, and as at 2012 or 2013, it was not yet a policy recommendation in Nigeria. And so when WHO recommended it, there were so many questions that were being asked. How do we implement it in our context? How many cycles should we implement? How should we deliver it? Should it be taking the drugs from house to house, or should we have a fixed post where we ask the community members to bring their children? So this intervention was implemented as a pilot in Katsina State in 2013. So Malaria Consortium was the first to implement that intervention to help Nigeria gather evidence around feasibility, acceptability, and cost of implementing that intervention in order to help them take a policy decision about including SMC in the malaria guideline. And so the objective of this intervention was to, find an appropriate community-based delivery system for SMC. We also wanted to execute it, carry it out, implement it, and then find out what is the cost, how much does it cost to implement it, and of course, evaluate the community acceptability of that intervention as well. So we designed this study as a 2-arm, non-randomized controlled study with mixed methods, a mixed method approach of collecting data. So it had both quantitative and qualitative components. The quantitative component looking at the baseline, and then the end line looking at what is the malaria situation before the intervention, and then we implement the intervention and then check again to see what is the malaria situation afterwards. Sentinel sites were set up to monitor malaria cases that are coming to the facility in both the intervention and the control arms. And then we also had these key informant interviews, focus group discussions with the caregivers of eligible children who are aged 3 to 59 months. And so that intervention occurred over 2 years. There were 2 rounds of SMC, and the results showed that mothers were accepting of the intervention. They loved it, they wanted it. So acceptance was very high. We also found that it was feasible to implement SMC as a house-to-house strategy. We tested both the house-to-house and the fixed post, and the house-to-house was preferred because it cost less for the caregivers to be able to access the intervention. And then looking at the results, the effectiveness of the intervention was also measured. Looking at this chart shows the LGAs where SMC was implemented, and this was the control. And at baseline 2012, you can see the green bar represents the malaria cases, trends in malaria cases at baseline in both control and intervention arms. And you can see the period between July and November, those 4 months is the season where the malaria cases are highest. That is when malaria transmission is highest. And so when SMC was introduced in 2013, in the intervention arm, the red line shows the malaria cases in 2013. And you can see the difference between the peak during those 4 months and what it was at baseline, and compared to the non-intervention arm. And then in 2014, the second round of SMC was carried out. And you can see that even here, it had dented the peak of that malaria trend. But then in the control arm, you see that in 2013, in fact, the number of cases went up. So these results contributed to SMC policy adoption in Nigeria and the subsequent scale up from 4 local governments in Katsina State then to now 21 states in Nigeria. So Malaria Consortium's SMC portfolio has therefore been growing since then. So from 160,000 children then in Katsina in 2015, because of that result, we were also able to access some resources to implement the Access SMC grant, which was implemented across 7 countries in Africa, in sub-Saharan Africa, reaching 7 million children. Beyond that, we have also been able to now access the philanthropic funding from GiveWell that, provides support for over 21 million children being reached with SMC through Malaria Consortium's SMC program globally. And so there's been tremendous increase in the number of children that are accessing SMC globally. Currently, there are over 49 million children across 17 countries that are receiving the intervention. And so, again, still looking at, the SMC platform, there is a huge body of evidence around integration of interventions. And looking at, a huge body of evidence about integration of intervention using existing platforms to do more. And we found that that platform that delivers SMC, what happens is that every year, 4 months in a year, July, August, September, October, depending on when rainfall starts, community health workers, massive numbers of them, they go from house to house to give children who are aged 3 to 59 months sulfadoxine, pyrimethamine, and amlodipine as treatment to prevent them from having malaria. So they go every 4 months, every year, and that's been happening since 2013. And like I said, 49 million children across the world are being reached. So we began to now think that this platform that does this, is it possible for this platform to be used to do more than just delivering SMC? And so we began to look at what evidence was available to support this. And several evidence is available to support, using that platform. Matthew Caldron et al. Argue that the lack of integration between SMC, EPI, and nutrition program could be a missed opportunity. And coverage of, LNA improved significantly by just dropping it on the SMC platform. And we know that community health workers can deliver health services that are previously restricted to skilled health workers. So in Nigeria, we have this task shifting policy where some health workers, some health services that previously used to be delivered by just health workers can now be delivered by community health workers. And so looking at this evidence within Malaria Consortium, we now began to look at how we could layer other interventions on top of that platform that we have. And so in 2 countries, Togo and South Sudan, we are using the SMC platform to identify zero-dose children for immunization. So as those community health workers go to the house, as they are providing SMC, they are asking questions about immunization status of the children, and those that have not been immunized are referred to the health facility to be immunized. We are also using the platform in Nigeria currently to check a hybrid model for malaria vaccine delivery. Malaria vaccine has just been recently approved and rolled out in Nigeria, but there are issues with uptake. And so we are looking to drive the uptake of malaria vaccine. And then also the coverage, improving the coverage of vitamin A. Vitamin A is a life-saving intervention, but the coverage is very low in Nigeria. And so we're also looking at that. And I'm going to be talking a little bit more about this as a case study. So the second case study is the study that was conducted to look at improving the coverage of vitamin A by layering it or integrating the delivery of vitamin A with SMC. And so this intervention, again, was looking at riding on the platform of SMC that has been well established, accepted, and also loved by the community. And it reaches more than 90% of the target population. And so we looked at the states where we were implementing SMC in Nigeria, and we realized that the coverage of vitamin A in those states was very low. Sokoto, as an example, this was done, there were 2 pilots on this. The first one was in Sokoto. And in Sokoto at that time, when we did the baseline assessment looking at the coverage of vitamin A, it was 2% in the area where we were implementing SMC. And the children who are eligible for vitamin A is the same age group as those who are eligible for vitamin A, for SMC. And we're reaching 98% of those children with SMC. But then the coverage of vitamin A was 2%. So we designed this implementation research to ask the question whether it was possible to integrate vitamin A delivery with SMC implementation. And we did that. And the results show that, yes, it was really feasible to do that because the coverage moved from 2% to 59% for vitamin A. And it did not affect the quality of SMC implementation, neither did it affect the coverage of SMC. However, that's when we disseminated this result to the stakeholders. They had several other questions that the research did not answer. They wanted to know how much does it cost to add vitamin A on top of SMC. They also wanted to know, are there safety issues that we should be worried about? Are the community health workers actually able to determine eligibility? Because vitamin A, you must not give it, there's the risk of vitamin A toxicity if you give it, less than 4 to 6 months in between. And so we designed a second study. This one now was funded by the Health Campaign Effectiveness Program of the Global Health Campaign Program. And this one was now done in 2 local governments in Bauchi State. And it aimed to answer those questions around feasibility, acceptability, as well as looking at the effectiveness of the intervention, equity, does it reach all the children, safety, what is the adverse drug events that are being reported with that integration, and then also looked at the cost of implementing the intervention. And so the results showed, again, that yes, it was feasible because we were able to achieve very high coverage of vitamin A in this particular study. At baseline, it was 1.2%, and it increased significantly to 82% at endline. The same thing for coverage of endline. Statistically, we saw also that it did not affect the quality of SMC delivery. However, in fact, rather, it improved the quality of SMC delivery because the first dose of SMC was supposed to be delivered as directly observed treatment. And when we checked, we used that as proxy for quality of implementation of SMC. And we found that, in fact, it improved that directly observed treatment when we co-implemented it with vitamin A. And then when we looked at safety, also, we did not see any significant increase in the number of adverse events that were reported after the integration. And so the other question about equity was to check whether there was a difference between children who received the intervention and those who did not receive it. In other words, is this intervention reaching everybody without any inequity in it? And we didn't see any difference between those who received it and those who did not receive it in terms of age, sex, religion, wealth index, and also even the occupation of the household head. However, we saw a difference between those who received it and those who did not, in terms of where those children lived. And we saw that children who lived in urban settings, in urban areas, were less likely to be reached compared to those who lived in the rural areas. And this was similar for both SMC and vitamin A. And it just points out that when you integrate an intervention, because I mean, this is something that is well established already for SMC, and they are trying to do something about it, that coverage in urban area is usually less than rural area mostly because of the gated estates. People who don't open their doors, they're not able to reach the children. They put their children in creches and you'll not be able to reach them. And so because that is a peculiar issue with that platform, the intervention we put on that platform also experienced the same thing. And so in terms of cost, the total cost per child receiving only SMC was 94 cents. And then when vitamin A was added, that cost per child increased to $1.18. And so when you look at the incremental cost of adding vitamin A on top of the SMC platform, it was just about 24 cents, which we found to be something that was cheap. Now, let me quickly take you through the last case study, which is using simplified low literacy tools for treating severe acute malnutrition at the community level. It was also a feasibility evaluation in Nigeria. And just to mention that this is published, and if you want the details, you can find in that publication. So basically, we know that in Nigeria, the coverage of the nutrition program is very limited. It's only about 156 local governments. I don't know whether that has increased beyond that now. Only about 156 LGAs are covered with nutrition program. And that means it's just about 2 out of 10 children with SAM that will have access to to treatment. Uncomplicated SAM cases are treated at OTPs, but these OTPs are only accessible by just a small subset of the population. And we also know that the ICCM, which is the Integrated Community Case Management of Childhood Illnesses, is a platform that has been recognized to increase, life-saving treatment. But malnutrition in that platform only identifying children with malnutrition. So they are identified and referred. So if there is no referral center around, most times those children don't go and they don't get helped. So we, again, look community health worker program, providing ICCM in the community, in the communities where we were implementing, we were operating then. We again asked to see whether those community health workers can treat severe acute malnutrition at the community level instead of referring all of them to the health facility. Is there a proportion of them, depending on how severe they are, that can be treated? And so a non-inferiority study with a mixed methods data collection system was set up to check, to evaluate the feasibility and acceptability of using a simplified tool for community management of SAM. So we trained those health workers, those community health workers. They are basically volunteers who are living in the community. They have no health background, but they've been trained on, how to treat malaria, pneumonia, and, malnutrition in the community. So we train them on this new algorithm for managing SAM. care, B, 4, 5, depending on where the child falls. So that tells the community health worker the dose of RUTF to give. And then one you now also need to calculate how many of that child to take home. So we have this dosage calculator. So he places this on the floor. Each one represents the dose for each day. This is for a 7-day treatment. So the community health worker places all that, and that helps. The mother takes it home and treats the child. Follow. So there's the flip chart that he uses to counsel the caregiver, and then there's the register that he uses to do the registration of the children. And then this is what the simplified algorithm looks like. So the child comes in. If it's green, is normal. If it's nutrition, it receives counseling. If it is yellow, receives counseling. If the child falls in the pink zone, an appetite test will be done as long as the child does not have any complications or any danger sign. That child does an appetite test. If she passes the appetite test, it goes on to be weighed and then gets into the program. Same thing for the dark red. However, if it is deep red, it goes directly to the health facility on referral. So in terms of follow-up, this is the guide for the follow-up for the children. So when children are usually in that program for about 3 to 12 weeks. And if the child is red, goes to the health facility. If the child has 2 greens in a row, that child has recovered and is discharged. If the child misses 2 visits in a row, the child has defaulted. Sometimes they do follow up to check why is this child not coming. And then MUAC is below admission MUAC. That means the child has deteriorated, they refer. And if by the 12th week and the child has never had 2 greens in a row, is a non-response, that child is also referred. Otherwise, they continue treatment. So the results, it showed that most of the children that were recruited into the treatment of SAM at the community level were in the less severe range. They were all in the pink zone. So you can imagine 80% of them were in the pink zone, which means they were just borderline severe. And they recovered within 6 weeks of follow-up, while 20% of them were in the dark red zone. So overall, 73% of the children recruited into the COPS treatment for SAM recovered. And we found that the cure rate was high and it was not inferior to the sphere humanitarian standard of 75%. Although referral was a little bit difficult, given that the caregivers, care was provided free of charge. So when you ask the mothers to take their own children to the health facility, they will say, you are treating other children, why are you not treating my child? And so it was difficult because they would need to transport themselves to the health facility and all that. The program was well accepted by the COPS. They listed reasons such as free care and shorter distance to reach care as positives. And caregivers indicated that a child's successful recovery and the service being free were some of the positives. So just to mention that it is not all these interventions that, this particular intervention is yet to be scaled up in Nigeria, even though the results were good, they've been disseminated to the key stakeholders, but this is yet to take off. So I would share a little bit on some of the lessons that we have learned in implementing in some of our implementation research projects. One is that thinking about that pathway to scale from the beginning is very important. So when you are designing the program or the research, you must already have scale up in mind, that if this was going to be scaled up, how would I design it? Because that then helps you to develop a research uptake plan that helps you to implement certain activities while you are implementing your research. Country ownership is also very critical. And, you know, Professor Ogundawusi has talked a lot about carrying the stakeholders along. One of the things that helped us, or that one of the strategies we use for our implementation research, is that we usually would have a very elaborate stakeholder engagement, co-creation of the design of the research, asking them questions, you know, trying out the tools with them before we even implement it at all. And that's been very helpful. Coordination is also key, especially when it comes to integrating different interventions. For our vitamin A project, for instance, vitamin A sits with the nutrition people. Malaria SMC is another group. And then you have, you know, the child health group, you have data managers and all that. So it was really creating a platform that will bring all of them together, called the Core Planning Committee, so that quick decisions can be taken in the course of implementation. The study design also must be well thought out to ensure that the study questions are answerable by the design. Very important. And partnership and engagement at global level also we found to be very useful, because while we were implementing the SMC program, especially for the Access SMC, that engagement at the global level also was put in place in the form of the SMC Alliance. And also now we are doing perennial malaria chemo prevention, and there is a community of practice that have been set up where results that are coming out from some of the implementation studies across the countries are being shared in that forum to help to inform the design of other countries' research and so on. Routine data within the context of an implementation research is also critical. So balancing between improvements in data recording and integration with the National Information System was also very important. And then carrying everybody along, both at the national level, at the state level, at the community level, also important. Communication is key, because the chance of adoption of a strategy or intervention following a successful IR could actually be impacted by how you communicate the results from the study. And again, giving an example of, you know, our SMC and vitamin A study, it was very successful in Sokoto, also very successful in Bauchi. But do you know that by the time we now got some funds, because we only implemented in 2 local governments in Bauchi State. And then one of our funders for SMC said, oh, these results are very good, and I think this will be a cost-effective intervention. Can we take it to scale in Bauchi? And then we said, oh, yes, we can. And then we re-engaged. By the time we started re-engaging with the state, this if you take it away, MSH cannot be taken out of MSH. And so we're still in the middle of, you know, convincing them to say that, look, but MSH week is not the vitamin A across board. We've been doing it for many years. HS survey, vitamin A in Nigeria has declined from 42% in 2018 to 36% now in Nigeria. So the question is, if something is not working, should we keep using that thing? But miss them and show them the reason why they should be successful implementation research may not result in adoption of the intervention or the strategy, because there are so many other parameters that have to be considered in that, decision making. Prof again talked about that, earlier on, about the process of decision making for the politician is quite different. There are many things they consider. You can have a very beautiful intervention, and then when they ask you, the absolute cost and look at other priorities that they have, and it depends on where it falls on their for it to scale through or not to scale through. So in conclusion, implementation research is an important tool in the translation of research to policy and practice. And we've demonstrated this severally. And we know that operational and implementation gaps in country programs can be addressed with implementation and operations research. However, implementation research is both a science and an art. It requires a combination of both the application of rigorous methodology and creative problem solving, adaptation, and a deep understanding of the context. We've talked about the fact that it worked here does not necessarily mean that it will work in another place. And we need to look at those contextual factors so that we can effectively navigate the complexities of real-world settings where solutions are not one size fits all. So, Prof talked about, the fact that many times we do research and we keep the results under the table. And I wanted to just mention that, many of the work that we do, we go beyond just doing it, disseminating it. We also go into publishing them. And so a lot of them are available in publications. You can find them on our website if you are interested in looking at the details. Thank you very much for your time.
Thank you very much. Let us give another round of applause. I want to say that IPH is proud to be a partner of Malaria Consortium. Thank you for the work that we have been able to do. You've engaged us in and continue to engage us. There's a new partnership that was proposed, and we are glad that we can work with you. So thank you. Let's give Dr. Oresanya another round of applause. All right. So we've listened, we've learned, maybe for a few minutes, but I would allow, it's not in the program specifically, but just for a few minutes, I will allow for maybe questions, comments, clarifications, maybe one or two. If there's anybody in the audience, I'll give that allowance. Is there anybody? If there is, I'd like you to show your hand. Anybody? All right, I can see one. Okay, maybe one more. Any other person? Okay, let us welcome Dr. Titus. Please come over. Okay, please, the mic is coming to you. Let's give Dr. Rachel Titus a round of applause. Kindly let us know who you are directing your question to.
Okay, I think the question is to both our speakers. My name is Rachel Titus. I was formerly in IPH, and I'm still enjoying an ongoing and consistent relationship with the Institute. My question is, I'm not sure it's a question. We know that the politicians think differently from us, and they have their own targets. And we, on this side of the academia and the different agencies that come up with researches that are very, very useful for the health of the public. We also have our own goals and purposes. Now, why don't we start thinking like the politicians in a way? Like I'm looking at this kind of gathering, is it possible we bring them on board? They see these things that we are putting across and start, you know, if you're talking of diplomacy, talk of how they engage people, let's start thinking politically so that we will not be frustrated when our results, very useful results, are not being taken up. Because sometimes it's just because we're not looking at the way they are looking at things that some of these researches are not really being implemented. So I just felt like I've had that experience before. You have something you've developed and you want to put it out there for adoption, and somehow you're frustrated because for some subjective reasons, one or two persons would think that, oh, this is not what we are focused at that particular time. So maybe the question now is, how do we engage the politicians, the policymakers, the persons and the people, the stakeholders who would turn our research outputs and turn them into policy and practice? Thank you.
Thank you very much. All right, I'll give to Prof first. Maybe I should comment that, does that include joining the parties, APC, PDP? Is that the question?
It doesn't have to include joining the parties, but I like one of Dr. Oreswea's conclusion that prevention research is both a science and an art. So you need some people skills to engage this class of people. So that's on one side. Yes, part of the stakeholder engagement is getting them to be in settings like this. Sometimes you hold community outreaches, Durbers, depending on where you are, where you engage them and get them to know what you're doing, but also, very, very important, to also know what they are looking for, what they desire. Because one of the things I said, that one of the determinants of whether your research output is taken up is whether it meets the needs or it's demand-driven. IR has to be demand-driven. Is it driven by the demand, the gaps, the needs that are really identified by the policymakers, the politicians, the implementers, and the people that need to use that knowledge?
Thank you very much. Please let us give him a round of applause. Dr. Oreswea.
Yeah, thank you. So I think one of the things that we also need to understand is that many times the politicians think in terms of numbers and figures and money. So we also need to begin to think about how we communicate our results in a way that they are able to understand it. So, for instance, we've begun to think about communicating the malaria burden in terms of economic burden. So you have the economic burden of malaria. So when you go to the House of Assembly and you say that Nigeria is losing so billions of dollars because of malaria, then they're like, are you serious? You mean really if we control malaria, we can save this kind of money? Yes. If you control malaria, this is how much you are going to save. And then they become interested because now you are speaking their language rather than saying, every day 2 children are dying of malaria. They don't understand. But the moment you're talking about return on investment, you start talking about cost savings, you start talking about economic benefits, then they are interested. So the way we also communicate our results is important. And then also, going back to what Prof said, that from the beginning of research, they must be involved. They need to be involved. You need to find out what is it that you did to help you to take this decision so that your research is designed to answer that question. In the malaria program now, the way we are engaging with NMEP is that we don't just sit down in our own office and design a study. There is a research agenda for the malaria program that has been jointly designed by all program implementers, the program itself, and everybody that is involved in malaria control in the country, to say that these are the questions that we need to answer to help us improve implementation, to help us, generate evidence on impact of what we are doing. And so if anybody wants to implement any research, you go to that agenda to go and look for a question, so that when you answer a question in that agenda, you can be sure that it is feeding into a system that will accept it. I give an example of perennial malaria chemo prevention. Is a new intervention, but not really new. It used to be IPTI. Now they've called it PMC, and the way WHO has designed it is completely different from what we used to know as IPTI. So meaning that we need evidence to implement it in the country, for countries to even adopt it as a policy. So the first thing we did was to call NMEP and all the stakeholders and say, okay, what does Nigeria need to take a decision about PMC? And they said, okay, we want to know, does it work? How much does it cost? What are the number of touch points that we must implement? And those questions were identified. And then the implementation research was designed to answer those questions. So once the results are out, we go back to them and say, okay, these are the results of the questions. And because they were involved in formulating the question, they cannot now say, oh, we don't want the results. So it's about speaking their language and also about co-creating the study with them. Thank you.
Thank you very much. So one of the newest buzzwords in the research world is co-creation. So I think it's something that we need to look at as researchers. Okay, one more question, Dr. Eson. Brief one. Please let us welcome Dr. Eson very briefly. Yes, please give her the mic.
Questions are a bit quite basic. One, when you talk to real life settings in implementation research, can you maybe expatiate? Is it not okay when you go to the field and implement this idea amongst people, which is also what you do in any other kind of maybe interventional research? So is there anything particularly that makes it different in implementation research? At some point in time when we're in the discussion, I was wondering, is it really easy for an academia to do implementation research besides building capacity? Because you have grants, the products, and I go to test and then I scale up. But at the same time, I thought, well, maybe one could still look for something simple, like maybe a teaching methodology. I also add a bit to that. And then finally, my last my last question is on Dr. Arije. Looking at you has made me almost forget my question. So painful. So painful.
Okay, maybe let me answer the first one so that maybe remember the second one. So you wanted to know the difference between real world setting and, okay. So when we say you're implementing a research under real world conditions, what it means is that you are not controlling the conditions at all, unlike what you do in an efficacy trial. So if you are doing a trial, for instance, and that trial will also be done in the community, but you are in control completely of who receives what and who doesn't receive what. You are also in control of the environment. If a mother is, for instance, if we take SP, for instance, and your intervention is that this child must receive 3 doses of SP over the next 2 years, you will make sure in your study that you have made facility available for that child to receive those 3 doses, even if it will mean paying transport fare, ensuring that the child gets to the health facility, and making sure the health worker is there to give. You understand? But in a real world setting, you have no control. You withdraw control. You just put it there and let it run. You train the health workers, you give them instruction, and then you step aside without pulling the context. You understand? So that is where you will then get to see what the health system's issues are. That's when you will now know that there's no water to mix the drug or for the mother today. So if you want to do directly observed treatment, the mothers have come, no water. Water is not running. So that day, they will not receive it. So that goes into your results because you are factoring, because when you eventually implement that intervention, that's exactly what will happen. So doing it as an implementation research helps you to already identify what the bottlenecks are. Then when you are now implementing, you now create interventions to address those bottlenecks. Okay, there's no water. How do we deal with the water issue in the health facility? Okay, so that when you now implement, you will not have that as a bottleneck. I hope that clarifies.
Perfectly. Thank you.
Thank you, Baron. Please, let's give her a round of applause, sir. You want? Okay, so the question has been.
You're also saying that IR seems to be expensive. Actually, IR is considered a lot cheaper than clinical trials or some of the other clinical studies that you would engage in. It's not that expensive.
Oh, thank you very, very much. We're very, very grateful. All right, so now we're going to have presentation of plaques to our guest lecturers for the beautiful job they have done. And I'm going to invite Professor Fatusi, who is now wearing like 5 caps in this meeting today. And I would invite the guest lecturers one by one. Please let us, with a loud ovation, welcome Professor Olumide Ogudansi.
Tempted to wear jeans and t-shirt this morning. Thank God I didn't. I'm sure we've all had a very wonderful time, and I'm sure it's been most stimulating. And therefore, on behalf of the organizers and on behalf of all of us who have been privileged to be part of this wonderful program, I'd like to present this to Professor Olumide Ogundansi, thanking him for the honor he has done us and trusting that, like the DVC academic said, he will soon be back somewhere between this community, one way or the other. When he comes back, the university will pay the royalty to me since I thank you very much. Congratulations, sir.
Thank you very much. Almost, sir. Let us welcome Dr. Olushola Oresoya.
Shola and I do not only share some common points in terms of being alumnus of OAU. We also share the privilege of being co-alumnus of the Brown School of Community Medicine, Public Health and Community Medicine, Hebrew University at Dasa, where you get some of the best epidemiologists anywhere in the world. So I'm so proud of you. I was telling Maureen, I said, oh, Maureen, I forgot to mention that Shola is speaking next. So, oh, Shola, fantastic. She's such a great person. I look forward to meeting her in February when I come, and hopefully Professor Ogundansi will also be there in February. So on behalf of all of us, thank you for the wonderful job and thank you for the excellent job you are doing out there, representing us so well and communicating so powerfully, even at the opportunity we have out there. Thank you very much, Shola.
All right. So we are gradually coming to the end of this program. But before we close, we have to celebrate again the icon that this lecture series was named after, whose today we are celebrating. And of course, today is also his posthumous birthday. And on this lecture series, so I'm going to invite to be joined by our DVC former DVC Emeritus Professor Togodu Beckett Stets. I believe I got that again.
So, it didn't come to school early enough. So that on behalf of I pledge. I plead guilty, and please for forgiveness. Professor Fumi Togodu Beckett Stets. Please,
Professor, please kindly also join Professor Mrs. Fatusi. Please kindly join, and the director as we do this cake. Thank you very much.
All right, while we are waiting for these, I'm sure that for all of us, we've had some very stimulating time. Can you begin to ask yourself, for example, what can you do with this? With the knowledge that you've gotten today? I know a lot of us are from public space in different dimensions, resident doctors, professors, consultants, students. Can I ask you, what do you think you can do with this knowledge while we're waiting for this? Anybody wants to tell me? Oh, all right, man.
Please, I have a question. Very stimulating lectures from both of you. And I was just wondering, most of the public health engagements are always with children. How about with elderly?
Fantastic question. I will give it to Shola first.
Okay, I'm sure there are programs for the elderly. But the thing is that the kind of disease that we are focusing on, malaria, children are most vulnerable and pregnant women. So that's why the focus is usually on them. But there are programs that also target elderly.
Also considered and focus for the elderly.
And I agree with you, man. I don't think we have done enough for the elderly. I guess the problem is that for many, many years, we have been a nation that loses a lot of our women and young children. And so the challenge had always been less. But we must also realize that we are becoming increasingly, the aging population is increasing. And I think it's something we must begin to think very, very seriously. We don't even train specialists in geriatric medicine. But I guess we are getting there gradually. And I do hope that very soon there will be daycare for elderly in Ile-Ife, that people can come together in the afternoon. Yes, very, very soon. In next year, I'm convinced that there will be one. So, we'll look forward to that, and then I'll reach back to you when that time comes. Thank you, ma. She has just saved you from my question. All right, we'll go ahead, ma.
Thank you very much. All right. So to do the cutting of the cake, we'll just okay. So okay, thank you so much. So we're going to spell the name. Oh, okay. Okay, so we're going to spell Lucas to commemorate this cutting of the cake. And after the last S, the last letter, the cake will go. So let's go together. I want to go L-U-C-A-S, Lucas. All right, thank you very much. Thank you very much. Make sure you get your taste of the cake. Thank you very much, Saz and Mas, our distinguished guests and our guest speakers. Thank you very, very much. We are very grateful. We have maybe 2 more things to do today, and then we'll call it a day. And for the penultimate one is closing remarks. Again, I'm going to ask Professor Adesegun Fatusi, who is representing the VC, to give the closing remark. Thank you, sir.
Thank you. The provost, Professor Benis Hadimengbe, the director of the institute, Professor Olakunje Sumai, our 2 esteemed guest speakers, Professor Olumide Ogundansi and Dr. Olusola Oresanya, our mommy in the house, Emeritus Professor Fumi Togonu Bikesket, Professor Mrs. Ogundansi, Professor Mrs. Fatusi, other professors in the house. Ladies and gentlemen, it's been a wonderful time today. And just to bring us back to a point that the DVC mentioned, that one of our commitment as an institution is to continue to further the various dimensions or avenue for improving knowledge and to move knowledge to action. I therefore think that today must stand not just as just one program that had come and gone, but must be a catalyst to our work and our thinking as university scholars, as students, to say, let's do research, but not let research end as research. Let our research truly begin to impact. Let our research begin to transform our community. Let it make a viable difference around us, so that people can truly see the reason why we're here. A couple of years back, I was part of an argument in Johns Hopkins University. You know, Johns Hopkins University has the #1 school of public health. And then if you go a bit further, you get to this very terrible community. And the argument was, you are the best school of public health in the world. Why is the light not showing here? I'm sure that they started what they call an urban project headed by Professor Blum, who happens to be my mentor. I think that one of the things we must also take around is that our environment must become different simply because we are here as a university. And of course, this university has continued to make that impact. But today is a call to action, a challenge that we can do more. And therefore, I want to thank on behalf of everybody again, to thank our esteemed speakers that have come all the way. Professor Ogundansi didn't come from Lagos. I can't even remember what the state is. It's one state that when you get to Lagos, you take 3 hours to get to his house. And he came very early this morning, all the way. And I know he's going to be going back because he's such a busy man. Shola had come since last night and she'll be here with us till tomorrow. So I want to thank everybody. And again, I want to pay special tribute to Emeritus Professor Togun Bekeskets. I do hope that when we retire like you, we will also be coming along because it's such a great encouragement when you see our mentors, our very senior people who continue to be around to encourage and to challenge us that there is more life ahead. So on this note, ladies and gentlemen, on behalf of the University Vice Chancellor, I want to thank you very much and wish you just a very wonderful afternoon and greater time of impact ahead of your soul. Thank you.
Thank you very much, sir. Please a warm round of applause. Thank you very much, sir. Now I'd like to invite the IPH Secretary, the President of Mr. Tope Oyegunle, for a vote of thanks. Please let's welcome him.
Good afternoon, everyone. I was afraid because Professor Adesegun Fatosi had already thanked everyone. The chairman in absentia and the members of the I table. It is my honor and privilege to to present this vote of thanks. We really appreciate our time and presence in this lecture. Our presence, our contributions have made this very huge success. We want to thank our guest lecturers, Professor Olumide Ogudanzi, accompanied by the wife, and Dr. Olushola Oreshonya. We thank you for the thought-provoking and the insightful presentations. We have gained a lot from the lecture, and we hope that what we have gained, we are going to translate them to action that will bring a kind of benefit to the public. So we want to appreciate our chief host in absentia, the Professor Aderom. He was unavoidably absent from this program, and we're appreciating our host, the Provost of the College of the Sciences, Professor Bernice Adegbenbe. She has been supportive of the Institute of Public Health since she became the Provost of the college. We appreciate you, ma, and we pray for continued enablement by God. We appreciate our host, our co-host, which is our director, Professor Esimai, for putting this together. She has been up and doing since we started planning the program. And we would like to appreciate our mommy, Professor Mrs. Fumi Togonum Bekeskets. We appreciate you. We value your presence here. We thank you for coming. She is not only she wasn't the former DVC, she's also a pro-chancellor of Federal University. And we appreciate you and we cherish your presence here. We want to appreciate also our past director. We have a Professor you come to the College of Sciences. So we also like to appreciate our deans of faculties, the HODs and the heads of department, and our directors of Institute of Ecology, Director of Cultural Studies are here present. And we're appreciating our invited guests from outside the university, from OETC, from 7 Day, and our staff and students in the college. We appreciate your time. we appreciate your presence, and we look for more of your presence when we have programs like this. So we want to thank the organizing committee of this very program. I think under the able leadership of Dr. Olujide Arije, they've done wonderful work. So let us just put our hands together for them to appreciate them. And for me to have I will not close this vote of thanks without appreciating the member of the committee. We have the like of Mr. Oluwatimileyin. We have Mrs. Miss Aliyu. Then we have Mr. We have Mr. Adeyeyi Odun. Then we have Mrs. Afolabi. So we appreciate your effort, and we wish you all the best. And I want to thank all our invited guests that traveled all the way from outside Ife. And we are wishing you a very safe journey back to your various destinations as we look forward for more collaboration in our future engagement like this. Thank you, and God bless you.
All right, thank you very much. So now we have come to the close. You've learned something. That implementation research is what art. All right, so we will take the closing prayer, and then let us stand up as we take a minute to pray. And so, Father, we thank you for a time that we've spent to learn, to be together. Thank you for all that has transpired. Thank you for all that we have received. As we depart from here, help us to be able to put to use for the benefit of mankind, for the benefit of this nation, the things we have learned, also to improve ourselves in the work that we do, that we may serve man and you better. Thank you for safety, for all that will be traveling and getting on the road. They will arrive to their destination safe. And thank you, Lord, because when we gather again like this for programs and other activities, we'll always have cause to rejoice and to see how much progress we've made in our lives and in improving our nation. We thank you, Father, for all of this. In Jesus' name we've prayed. Amen. Thank you very much. God bless you. Have a beautiful remaining part of your day. Yes, thank you. We take good pictures. All right, thank you very much. Please, our guests, please kindly permit our guests to step down before we leave so that we can take group picture outside. Thank you very much.